A pleasant good evening, everyone. Let's begin today's session with Omkaram. NMO mantra. Tvaham kamahe न स्वर्गं वा पुनर्भवं कामये दुःखतप्तानां प्राणिनां मूर्तिनाशनम्. A warm and heartfelt welcome to all participants of NMO AP Med-Katalyst Foundation, the 0-hour revision series. Today is day 11 of our 15 days rapid revision series, an initiative aimed at strengthening the fundamentals of first year MBBS students through focused and high-end revision series. Today, Dr. Madhavi ma'am, Professor of Biochemistry in ACSR Nellore, is going to take the session. Today's topics to be covered are vitamin B12 and folate and mineral metabolism. It's our privilege to have Dr. Madhavi ma'am with us today. We sincerely thank you for graciously accepting our invitation, ma'am. With great respect, now I would request Dr. Madhavi ma'am to kindly take over the session and guide us with your valuable insights.
Yeah. Good evening, everyone. And I am, as Lasya has introduced me, I am Dr. Madhavi Kondeti. I was the professor of biochemistry. Now I am working as superintendent GGH Nellore. So I'm not regularly teaching the first MBBS students, but it's my passion to teach everyone. So my passion is for teaching. So when Dr. Sagar has asked me to take a class, I was most happiest person to take the class. So here, so the topics allotted for me was like folate metabolism, B12, and mineral metabolism, and that too in mineral metabolism, it was the calcium which we will be concentrating more, because when I was speaking with the I think the Manoj or something, so they told me it is for the first MBBS students who are going to take the exam in forthcoming exam. So I would like to put my insights, like how if you write in your exam, you can be taken as I mean, your answer paper, answer script, when we go through your answers, how if we go through the answer scripts, how we will be taking the points, like if we see these points, we will be giving good marks for them. So in that way, I thought, okay, let me take the metabolism part of the B12 folate and then the mineral metabolism calcium. So I hope it will be very useful for you. So let's start the session. Yeah, Lasya. First slide. Okay. Is it visible? Am I audible to everyone?
Yes, ma'am.
Yeah. So as you all know, we all know that vitamins are being classified into two types, mainly the fat-soluble and water-soluble vitamins. And among the water-soluble vitamins, the vitamin B12 and folate plays a very crucial role in our metabolism as well. So, and in our first MBBS question papers also, we get often times the vitamin B12 and folate will be concentrated. Like we'll be giving, when I used to set the question paper, we used to ask what are the vitamins that are required for 1-carbon metabolism. And so we used to start the question like that, and then we'll go to the real vitamin B12 and the folate importance in one carbon metabolism. So like that, if you start, so vitamin B12, as you all know, I think you're already done your preparation. So it is only a brushing up your memory, that's all. So it's a water soluble vitamin, and it is also called as vitamin B12, the cobalamin. You all know it has got cyanocobalamin is the one which is naturally occurring form, and but the active form is the methyl form, right? So it is mainly, if you remember, it is mainly essential for the DNA synthesis and the red blood cell maturation and normal neurological functions. So usually it is, next slide, please. As I was mentioning about the forms of vitamin B12, the naturally occurring is mainly the cyanocobalamin, and that is also manufactured now as a synthetic cobalamin, and hydroxycobalamin. Methylcobalamin is the active form, and another active form is the adenosylcobalamin. As you see, the structure of the B12 is also very important, and so when you go through that one, uh, I think in chemistry you must have seen all the structures and all. If you are able to draw the structure of B12, that's well and good in your exam. Otherwise, at least try to write the biochemical composition forms. Okay, next slide. Yeah, so now coming to the sources of vitamin B12, usually we ask the functions and then the sources and the recommended daily allowances of the vitamins usually, and then the deficiency manifestations we'll be asking. And most often we will not stress on the management part or that thing, but usually you should know the deficiency symptoms, RDA, and sources of vitamin B12 and the biochemical functions, as well as we'll be more concentrating in the biochemistry paper. Okay. So now coming to the high vitamin B12 foods. Anytime, previous slide, yeah. Whenever you write about the sources of any vitamins or the minerals or anything, try to remember the richest sources first. So so usually we will be talking about the sources just for anything. When I used to ask, everybody will say like leafy vegetables is the first thing they will be answering in the Viva also. So vitamin B12, usually you have to remember there is a very no vegetarian sources are there usually. So it is mainly the non-vegetarian sources will be there. So here it is also showing like low liver from the mainly from the non-vegetarian source, and the oysters, shells, and mussels, fish. All these things will be having most of the vitamin B12. But what about how to see that it is exclusively found, it is found in animal derived foods, making the strict vegans for the part of the most of the vegans will become deficient. When I have been going through this one, I used to see some individuals who stopped the non-vegetarian diets suddenly they develop these symptoms of vitamin B12 deficiency. So because of that, we have to keep it in mind. If anybody is a pure vegan, we have to think of any, if he has symptoms of the burning soles and feet, and then any tingling, numbness of the feet and giddiness, all these things are related to the B12 deficiency. And nowadays, we are seeing many of the patients, and most of the patients are vitamin B12 deficiency. So we have to remember these things, and but how to provide for the vegetarian people, vegans, we have to see that one. Next slide. So if you come to the daily requirement, or we will say the RDA, that is recommended daily allowance, it is 2.4 micrograms per day for a normal adult. For a pregnancy, it is little bit more, like 2.6 micrograms per day. You all remember that during pregnancy and lactation, we need little more of any of the vitamins, minerals, or any nutrients. So it is little bit more in the pregnancy and lactation. Next slide. So coming to then how the dietary B12 it is taken when you take in a diet, how it is going to be useful for our body. That's how its metabolism, how it will be occurring. So dietary B12, it is released from the food mainly in the stomach, and it first binds to the R protein, that is the haptocorin, and it is in the duodenum, pancreatic enzymes degrade this R protein, and B12 binds to the intrinsic factor. This you have to remember very, like everybody has to mention about this intrinsic factor, which is secreted by the parietal cells of the gastric mucosa. So gastric parietal cells will be secreting intrinsic factor that is very essential for the B12 absorption. So the B12 intrinsic factor complex is absorbed in the intestinal lumen. So for the absorption of B12, you have to remember intrinsic factor is a must and should factor that will be secreted from the gastric parietal cells. So in blood, B12 binds to the transcobalamin, that is the transport protein present in our body, and it is mainly stored in the liver with while the body. So usually if it is stored in the liver properly, it will be utilized maybe up to 3 to 5 years. That's what they say. But I don't know. But our liver, maybe most of our people are having not that capacity of storing in the liver. So we are seeing many of people are having this vitamin B12 deficiency nowadays. When we used to be when we were in MBBS students, we were never knew of this vitamin B12 deficiency. But nowadays we are seeing, almost for the past 10 years, we are seeing a lot of people having this vitamin B12 deficiency, has to have their supplement forms like that, not from the naturals. Next slide. So this part and all you have to mention in your, like when you are answering in your answers, you can write in a what I will give you a tip, that whenever you are writing in a biochemistry exam, if you can represent your answers in a flow chart manner, that will be giving a fast, because when we are correcting the theory papers, we will be looking for the fast recognition of the answer, whether this person or whoever is the student knows the basic thing, first thing, and whether he can represent the whole thing in a flow chart like that. So you need not write the pages and pages and pages. So you have to write in an illustrative manner, and if it is completing in a flow chart, that will be very useful for the whoever is evaluating your paper. Then he will be having very easy to give you the marks. Next slide. This is the absorption that takes place in the B12 that we is. Now coming to the biochemical functions. Next slide. Yeah. So when we were talking about the functions of the B12, it is mainly a part of the enzymes which are useful for the one carbon metabolism. That was I was mentioning from the first slide. Okay, so the methionine synthase is the one which requires this B12 for the conversion of homocysteine to methionine. This is a very, very important metabolic process that requires, if the homocysteine level is increased, it leads to the atherosclerosis. So that is why we have, that is called hyperhomocystinemia. So, do you must be all be knowing what is methionine is? It is a sulfur-containing amino acid. That's a very important sulfur-containing amino acid, and which is essential for this mainly the one carbon metabolism. So, when the cofactor which acts for this metabolic process is the what we are talking about, methylcobalamin, the active form of a B12 vitamin. And also it regenerates the tetrahydrofolate, which is essential for the DNA synthesis. So very important function. Then what is the clinical significance of this one? So that's what I was mentioning. The deficiency of methylcobalamin will cause megaloblastic anemia and elevated homocysteine, that is hyperhomocystinemia, which is the main for the atherosclerosis of the vessels, blood vessels, which you all know, the atherosclerosis of blood vessels, if it occurs in the myocardial uh, vessel supply, then it will lead to the myocardial ischemia, and if it is not recognized properly, it will lead to infarction. So, which you all have to remember. Next slide. Then comes the other enzyme is methylmalonyl-CoA mutase enzyme. It converts methylmalonyl-CoA to succinyl-CoA. You should all remember what is the importance of succinyl-CoA. It is the one which, along with the glycine, it forms into the heme synthesis. So you all remember that, I believe. So the cofactor here again is a methylcobalamin, and the clinical significance, the deficiency, it causes increased methylmalonic acid, it is which is excreted in urea, and it condition is the methylmalonyl acidic. So you have to remember that. So then comes the neurological damage due to the abnormal myelin synthesis. So in abnormal myelin synthesis occurs if there is a deficiency of methylcobalamin, because it is present in the methylmalonyl-CoA mutase enzyme, which is essential for the conversion of methylmalonyl-CoA to succinyl-CoA, and it leads to also the important for heme synthesis. Succinyl-CoA is important for heme synthesis. So that's why it leads to one type of anemia. You all know which anemia it is. It is megaloblastic anemia. Next slide. So the functions of the B12 you can enumerate like DNA synthesis, as we have mentioned, and RBC, maturation of RBC. If maturation of RBC is not properly done, what happens to that? The megaloblasts will be there, and it will lead to megaloblastic anemia. And the function, other function is myelin formation. So myelin formation, it is mainly for the neuronal sheath. So if it is not properly done, then that is what is happening for the neuropathy. Okay, and nervous system maintenance is maintained through this B12. And amino acid metabolism, I told about the that is mainly between the homocysteine and the methionine. And fatty acid metabolism also, it will be useful in the metabolic process of fatty acid synthesis and all. Next slide. So now coming to what are the causes of deficiency, it is strict vegan diet as we mentioned previously, and the pernicious anemia, that is lack of intrinsic factor. If there is gastric parietal is not synthesizing properly the intrinsic factor, then it will lead to pernicious anemia. The main symptom of pernicious anemia is the patients, whoever is having this intrinsic factor deficiency, their deglutition, that swallowing will be difficult for them. And so the B12 deficiency also will be more in that one. So that in the pernicious anemia. Then in the cases of gastrectomy, because gastric parietal cells will be lost in gastrectomy, so the intrinsic factor again decrease, so pernicious anemia, and with the megaloblastic anemia. Ileal disease or resection, that example Crohn's disease also, when there is this resection of ileum, then there will be absorption is less. So again, the B12 deficiency will be seen. In pancreatic insufficiencies and fish tapeworm infestation and long-term metformin therapy, yes, this is the one which is being seen in most of the diabetic patients who are on metformin. There will be the B12 deficiency is more seen in them and leading to neuropathies. Long-term proton pump inhibitors used, like whoever is having the gastritis or acid peptic disease, they will be using this most of the proton pump inhibitors. For them also, we will be observing B12 deficiency. Next slide. So what are the clinical features? As you said, so there are two types you have to say, like hematological features and the neurological features. Hematological features, mainly with the megaloblastic anemia, fatigue and pallor will be there. And the neurological, numbness and tingling of the feet, or maybe sometimes the whole body may be having that. And peripheral neuropathy, that the burning sensation of the feet and palms also sometimes they feel it's very severe deficiency. And loss of vibration and position sense, that we will be testing in the feet. And the ataxia, if it is very severe, even the patients may feel stiffness in the body, and that leads to the ataxic gait. So the patient will be having ataxia, so he'll be having stiffness, the walking style will be changed, and there will be memory impairment, that is also called as brain fog will be there. So all these we have to remember as clinical features, hematological and neurological. Next slide. And coming to now, the other vitamin, water soluble vitamin, along with the B12, it is very important vitamin, folate, that is also called as vitamin B9, is a water soluble vitamin, as we all know. And the active form for this folate is the tetrahydrofolate, THF, which folate is a short form. So the primary role is mainly the transfer of one carbon units in the metabolic reactions. As we mentioned, that's what the essay form question we'll be asking. What is one carbon metabolism, and we'll be asking the vitamins and what is the important vitamins in one carbon and where their role, and then we'll go on to the folate or B12 functions, RDA and all. So you have to or it may be given as a very short answer question, 3 marks or 5 marks questions, as just simply saying vitamin B9 deficiency or sources, RDA and all. So either of the questions pattern will be given for the essay, or the 3 marks or 5 marks questions. They may be coming in the MCQs also, very, very important in this one. So the folate is essential for DNA synthesis, RNA synthesis, amino acid metabolism, and cell division. These are the basic functions of the folic acid. Next slide. So this comes here. You all know that there will be certain sources of folic acid. Usually, most of us will be thinking folate. Usually, will be best food of the folate is from the beans variety vegetables, mainly the lentils and all will have most of the folic acid from our natural diet. So you can see here all the lentils that are being displayed here. Okay, next slide. So when it comes to the requirement now, the folic acid is a very, very essential vitamin. Uh, it's during the first trimester of pregnancy. So why this is very important in first trimester? We will know that. So the requirement in adults, it is usually 400 micrograms per day. But during pregnancy and lactation, it goes to around 500 to 600 micrograms per day. Next slide. So coming to the absorption and transport, the dietary folates occur mainly as polyglutamates, but the absorption will occur in a monoglutamate form. So first from the polyglutamate form, this has to be get converted into the monoglutamate form, but it will be done by the intestinal enzymes. So the absorption occurs mainly in the proximal jejunum. So in the intestinal cells, folate is reduced to tetrahydrofolate by dihydrofolate reductase enzyme. The folate circulates mainly as a 5-methyl tetrahydrofolate and stored primarily in the liver again. So if your liver is properly working, then only all the vitamins and minerals will be utilized properly. So we have to keep our liver in a good functioning manner. Okay, next slide. So this is about like how the metabolism, the monoglutamate form is formed from tetrahydrofolate and then how it is absorbed. Okay, this you can go through in your book and get it memorized for yourself in whichever way you want. So like in ileum or jejunum, what it is here in liver and how it is getting stored in the liver. Next slide. So the activation first has to occur. So folic acid, dihydrofolate reductase enzyme will convert dihydrofolate into tetrahydrofolate. Okay, that and you all know that you have to remember that active form of folic acid is tetrahydrofolate and it acts as a carrier of 1 carbon units in the 1 carbon metabolism. Next slide. So what is this 1 carbon pool? Means tetrahydrofolate accepts 1 carbon groups from the amino acids serine, glycine, histidine, and tryptophan, and it forms the products, 1 carbon products, that is N5 methyl tetrahydrofolate, N5 N10 methylene tetrahydrofolate, N10 formyl tetrahydrofolate, and N5 for imino tetrahydrofolate. So these are the 4 forms of tetrahydrofolate that are required in the or actively participating in the 1 carbon metabolism. Next slide. So coming to the functions of the folic acid, it is mainly useful for the purine synthesis. You all know what are purines and pyrimidines, right? So very important for our, what is this important for? DNA and RNA synthesis. So you have to nucleic acid synthesis. So these are the very, very essential. Okay, so in purine synthesis, the N-10 formyl tetrahydrofolate donates the carbon atoms for adenine and guanine, which are the purines, and then it is essential for DNA and RNA synthesis. So if you remember the purine metabolism, then you will be, uh, yeah, in pyrimidine synthesis, N5 N10 methylene tetrahydrofolate converts the UMP to TMP, uridyl MP to TMP, and it is catalyzed by the thymidylate synthase enzyme, and which is required for the DNA replication. So these are the important functions of folic acid both in purine and pyrimidine synthesis. Next slide. Then coming to the methionine synthesis, as we are talking about, the sulfur containing amino acid is the methionine, and this is the very important amino acid we have to remember in the one carbon metabolism. The N5 methyl tetrahydrofolate transfers a methyl group to homocysteine, and that gets converted to methionine. This process requires mainly the vitamin B12. That's how this vitamin B12 and folic acid are linked in the one carbon pool. So, and it is mainly conversion occurs by the methionine synthase enzyme. So which is the cofactor that is required here is N5 methyl tetrahydrofolate. Next slide. Now, this is an important short question may be asked in your exams, that is folate trap. So in any, you may get for 3 marks, or any MCQs can be given, or so you have to remember what is this meant by folate trap. So in vitamin B12 deficiency, the N5-methyl tetrahydrofolate cannot donate its methyl group. The folate becomes trapped as N5-methyl tetrahydrofolate. The functional folate deficiency develops despite normal folate stores. So even though folate is there, because of vitamin B12 deficiency, the folate becomes trapped as N5-methyl tetrahydrofolate, and it cannot be utilized for the one carbon unit donation, and so that the folate, whichever is present, it cannot be utilized, and it leads to the functional deficiency of folate. So that is meant as folate trap. What is the clinical significance of this folate trap is both folate and B12 deficiency can cause megaloblastic anemia. So whenever there is a deficiency of folic acid, if you find it, so unless you give them the B12 along with the folic acid, then only that deficiency will be corrected properly. So this you have to remember. Next slide. Next.
Ma'am, 1 minute, ma'am.
So now, generally seeing what are the functions, we have seen all the purine synthesis, pyrimidine synthesis, methionine, and so that putting together, we can say the functions of folate as DNA synthesis, the RNA synthesis, it helps in, and the cell division, and the RBC maturation of RBC, and then fetal neural tube development. This is the main thing why I was mentioning the first trimester of pregnancy. It is very, very important vitamin that is required during the first trimester of pregnancy, because during which the fetus will be having this neural tube development. If this is deficiency is there, there will be anomalies will be there, and there will be mentally retarded children, and with anomalies, the fetal anomalies may be forming if this deficiency will be is there in first trimester of pregnancy. That is why we in any one with the first trimester of pregnancy, here in India it is mandatory for us. We will be supplementing them with the folic acid, because we don't know whether they are able to get from the natural food sources if they are eating or not. So we will be supplementing with the folic acid. And it is also very essential in the amino acid metabolism. Okay, next slide. So, what are the causes of folate deficiency? As we all know, it is poor diet, any malnutrition, and malabsorption syndromes. And in the alcoholics, if they are taking not, if they drink, so many people will not eat properly. And so they will have the, again, this B12 deficiency will be there along with the folic acid. And as I mentioned, the folate deficiency is seen mostly in the pregnancy, that is in the first 3 months of the pregnancy, first trimester. And in the folate deficiency, leading to the hemolytic anemia, where there will be many RBC will be lysing, and so it will be leading to the anemia. And the drugs, some drugs may cause folate deficiency, mainly the methotrexate, the trimethoprim, and phenytoin. Phenytoin is an anti-epileptic, as you all know. Methotrexate is an cancerous drug. So these used in the treatment purposes. Then this may lead to the folate deficiency. You have to remember that and treat them during these treatments. Next slide. This again, as I told you, in an illustrative manner, if you can in a manner, you can represent that in that manner, the folate, how it is metabolized, how it will be useful in the one carbon metabolism. Next slide. So now, so if there is a folate deficiency, what symptoms will be there? And if it is there is vitamin B12 deficiency, what are the features they'll have? So in folate deficiency, yes, we will have both the megaloblastic anemia in both. In megaloblastic anemia, there will be deficiency of folate as well as the vitamin B12. There won't be any neurological symptoms if only in the folate deficiency. But with vitamin B12 deficiency, there will be the neurological symptoms, and the homocysteine levels is increased in both the deficiencies. So we have to remember, and when there is a homocysteine disorder, hyperhomocysteinemia or anything, we have to think of folate and vitamin B12 and replace with them, so that the metabolism will get corrected. And then methyl malonic acid, it is normal in folate deficiency, whereas in vitamin B12 it will be increased. The folate trap is seen in vitamin B12 deficiency more than the only folate deficiency. Okay, next slide.
Ma'am, this is the last slide, ma'am.
Yeah, can we go to, okay, so I hope it is useful for all of you. Can we go to the mineral metabolism now?
Yes, ma'am.
Do we have the time?
Yes, ma'am.
Okay.
Ma'am, can you see the screen, ma'am?
Not yet shared. Still the last slide is showing.
Ma'am,
Last year, I think the screen didn't change, ma. So you all remember when the questions try to when I have observed who is going through the exam time. So you will be mostly spending your time on the writing in a essay manner and all. So when you put the bullet points and write whatever you know in a point-wise manner like that, that will be fetching. I mean, the time will be less for you. It will be taking, and the examiner, when he sees the paper, then he'll catch that okay, he knows the many of the parts of that answer question answer, then he'll get an idea which will fetch you more marks. That's what I have seen. There will be definitely difference between the evaluation of each examiner, but most of the examiners, what I have seen is like when we had an discussion, this is how they were expressing. So it will be a good, if it will be a good thing for you if you put write your answers in a bullet manner, like what are the salient points first, 1 2 1 2 1 2 3 4 5 6, just then you can describe each point like that. So this is my the tip for you. Yeah, now we can see the screen last year. Next slide. Go to the next one. This is trace minerals. Okay. Yeah. So we are talking about the mineral metabolism. So you all know the minerals are being again classified into macro minerals and micro minerals, or we can say minerals and the trace element, micro minerals and the trace elements. So among these ones, mainly when we think about the questions, what we get as an essays is mainly on the calcium, and then the iron. Iron will be very frequently asked in your exams. So again, it may be asked through vitamin D also sometimes, and the calcium mainly, or on a calcium itself is asked as an essay, and they may be giving you a case scenario type, like a boy comes with a short stature and bow legs, and with the fatigue and these things they may be describing about the case, and they will give the calcium level is like 7 milligrams per DL, and the phosphate something like 3.5, and then they may say that vitamin, what is the re- what is this clinical diagnosis will be, and then you can go on. Okay, if you say it is calcium deficiency, or so then what are the causes of calcium deficiency, what are the sources of calcium, how the calcium is utilized for the bones strength and all. So development, growth and development of that way also the questions may be asked as a case based question. So you have to be like aware of those symptoms, and then you can catch the deficiency and diagnosis properly. Can you make the screen? Okay. So is this the first slide? Oh. So now coming to the calcium, you all know that it is the. Is this the first slide? Is the first slide last year? in mineral metabolism? Mm-hmm. Okay, okay. Next slide. So it says the minerals are required for most of the vital functions in our body as vitamins and minerals. If they are deficient, they may be very causing daily, like we call it as a morbidity. So they may not, mortality means ultimately the death causing problems, but morbidity means day to day issues in our life, like whatever we want to do, like do the work in household work or what, and anything that we are not able to do as our routine thing, what we do every day, then that is called as morbidity. So it may be due to any disease or a disorder. So mostly the metabolic disorders will be causing this more morbidity. And if it is not, if it becomes severe, it leads to mortality. So remember that one. So the main functions of the calcium are calcification of bone, blood coagulation, neuromuscular activity, acid-base equilibrium, fluid balance, and the osmotic regulation. These are the general functions of the calcium. Next slide. So the macro elements and trace elements, the minerals are classified. Next slide. So the major elements which are essential for us are mainly the calcium, magnesium, phosphorus, sodium, potassium, chloride and sulfur. So you all know that we call or we name the sodium, potassium, and chlorides as the electrolytes also. And then the trace elements which are essential are mainly the iron, iodine, copper, manganese, zinc, molybdenum, selenium, and chloride. So you must have read all these metabolisms, but today I am supposed to take about the calcium metabolism. Next slide. So among these also we have the essential trace elements, possibly essential and non-essential trace elements. So the essential trace elements mainly the iron, copper, iodine, manganese, zinc, molybdenum, cobalt, and what else it is there? Fluorine, selenium, and chromium. So, so next slide. So these are the trace elements which are very, very essential. You all know the short notes or the 3 marks questions may be given about the zinc, and iron is very important in your when you are preparing for the exams. The calcium mainly in the macro minerals. Next slide. Should know about the electrolyte imbalance. That's a different separate distinct topic. So we are now concentrating today on the calcium. So the total calcium in the human body is about 1 to 1.5 kg. So 99% of this is seen in the bone and 1% in the extracellular fluid. So, is it only the bone it has? I think bone, muscle, and the extracellular fluid, what I can put it on. The sources of calcium, mainly here we have given it as a milk, which is a good source for calcium. Calcium content in milk is about, of cow's milk is about the 100 mg per 100 ml. But the requirement of calcium is very high for us. So we can't take 1 liter of cow's milk every day to get 1000 mg. So, okay, there are so many other sources apart from milk. So everybody says milk. So we can't drink so much of milk to get that daily requirement of calcium. So let us see the other sources which can be very useful than the milk, because Nowadays, whatever the milk we are getting, it is very, very adulterated milk we are getting. So anyway, milk is the source for any the children, growing children and all. But now they are telling up to 1 year only the child requires milk. So the pediatricians are advising to give the milk only up to first 1 year, and then keep on going giving the other food for calcium. So the egg, fish and vegetables are other very important sources of calcium. Then the cereals, what I say in cereals is, even though we take wheat and rice as our staple diet, I don't think we get much of the calcium from that. So it is mostly the millets you have to remember: ragi, jowar, all these millets type of cereals are important sources of calcium. And apart from that, we can say nuts and the till, which is we call in Telugu nuvulu. These are also very good sources of calcium and as well as the protein. So remember, nuts also very important source of calcium. And among the vegetables, usually the leafy vegetables will have the calcium. So we have to remember that. And the nuts and cereals, millets, we can say ragi. Next slide. So the daily requirement of calcium, I was mentioning, it was for an adult, we require 1000 mg per day, and a child about, as we all know, the growing age and the children who are growing, they require more than what an adult requires because their bones are growing. So a child requires 1200 mg, but now we are telling it may be required up to 1500 mg. So during pregnancy and lactation, compulsory, it is 1500 mg per day for both the mother and the fetus. So after the age of 50 again, we all know that our bones become osteoporotic in some people. So to prevent osteoporosis, we require more of the calcium. So there is generally tendency for osteoporosis, so which may be prevented by increased calcium, that is about 1500 mg per day. And at the same time, remember that just simply giving the calcium will not be helpful. So unless until they have sufficient vitamin D3, then their absorption will be better. That we'll be seeing. So we have to give along with the calcium, vitamin D3 should be there. Do you all know which vitamin D3? What is the source of vitamin D3, or where do we get from? We will it is also called as sunshine vitamin. So until unless you go into the sun and have a sun exposure, your vitamin D synthesis will be very less. That's why in nowadays we are seeing this vitamin deficiency also in so majority of the people, because we are now becoming the working inside the houses, or this concrete, this one, we are not getting exposed to the sun. So we are almost everybody is having vitamin D deficiency, and it has vitamin D deficiency has been given a very important role during COVID time, because during the COVID time everybody was not exposing to the sun, and nobody was going outside, and they have seen more morbidity and mortality in during COVID time, whoever is having this vitamin D deficiency. So you have to remember that also. Next slide. So the absorption of So absorption of the calcium is very important because it requires some special protein for this absorption of calcium. So absorption of calcium will be taking place in the duodenum and it is absorbed against a concentration gradient and requires mainly the energy. Energy is required for the that is ATPase. Sodium potassium ATPase is the one which is the gradient which requires this for the calcium absorption. So the absorption requires a carrier protein helped by the calcium dependent ATPase enzyme. Next slide. So and what is the vitamin that requires this factors that are causing increased calcium absorption is the calcitriol, which induces the synthesis of the carrier protein that is call binding or call modulin we call, and in the intestinal epithelial cells, and so it facilitates the absorption of calcium. So the parathyroid hormone increases the calcium transport from the intestinal cells to the bone. So in the parathyroid hormone also plays a very crucial role in the calcium absorption. So the acidity favors the calcium absorption. That doesn't mean that we we will be the acidity is very good for us. So it happens in the mild acidic medium, the calcium absorption will be more. So in amino acids, lysine and arginine, which are the amino acids required for in calcium absorption, you have to remember the lysine and arginine. Next slide. So this is the like process how the calcium will be absorbed by attaching to the receptor and then call modulin or calcium binding protein will be increased, and when there is the increased synthesis of this calcium binding protein, then there will be more of the calcium that will be absorbed. So important factors you have to remember: the calcitriol, the calcium binding protein, and then the call modulin. Next slide. So factors causing decreased absorption. So there are, you all know that there will be some factors which will be decreasing the absorption or obstructing the absorption of the calcium. Those are the phytic acid and there's oxalates, malabsorption syndromes. In certain malabsorption syndromes, here the fatty acid is not absorbed, and so causing formation of insoluble calcium salts of the fatty acids, and they can't be absorbed. Then phosphates, high phosphate content will cause the precipitation as calcium phosphate, and the optimum ratio of calcium to phosphate which allows maximum absorption is 1.2 to 2.1. So the milk contains this optimum ratio. That is why the richest source for calcium, we can think of milk as the richest source of calcium. Next slide. Calcium is mainly the how it acts in the cells. It is mainly the extracellular mineral, we can say. The cell membrane is generally impermeable to the calcium ions. And the calcium influx into the cell is by, as I was telling, sodium calcium exchange mechanism. And this mechanism is rapid but has low affinity for calcium. So entry is by a calcium uniport system. That means one side only it will be one side only which will be going into the cell. But calcium ions exit by a sodium calcium antiport system, which is in turn is dependent on the sodium hydrogen ATPase pump. This is called as calcium pump. So this may be asked as a short answer. So you have to remember how the calcium import is into the cell will be asked, or it may be asked in a MCQ also. Next slide. Whenever about these minerals or vitamins, they will be asking mostly about the sources, RDA, deficiency, manifestations, rather than on the absorption. Next slide. Oh, yeah. Activation of previous slide, ma. Previous slide, ma. Okay. So the major functions of the calcium we were telling, na? Okay. So the functions of calcium, as we have seen, it is the activation of the mainly enzymes. The colmodulin can bind with 4 calcium ions. That means, and calcium binding leads to the activation of the enzymes colmodulin is a part of various regulatory kinases enzymes. So means synthesase enzymes, we can call them as phosphofructokinase. All those you can take as examples. And some other enzymes are activated directly by the calcium without the intervention of colmodulin. And then in the mainly in the muscle, what does the calcium do? So the calcium, it mediates excitation and contraction of the muscle fibers. With this excitation and contraction of muscle fibers only, we are able to do either walking or talking, whatever it is, because of the calcium. Our muscles will be doing the contraction and excitation, and the action will be muscle action will be taking place. Then the calcium activates ATPase enzyme, and it increases action of actin and myosin and facilitates the excitation contraction coupling mechanism. Next slide. So the first function is activation of enzymes, mainly the kinases through colmodulin. In the muscle, it mainly helpful for the excitation and contraction of the muscle fibers. Next slide. So in nerve conduction, the third function is mainly the nerve conduction is necessary. Its calcium is necessary for the in transmission of the nerve impulses. So that's why whenever we have the calcium deficiency, we find very lethargic, weakness, fatigue, and again there will be some stiffness in the muscles because of this also. And then the secretion of the hormones. Calcium mediates, it acts as a secondary messenger, like cyclic AMP. If you remember in the hormone action, the calcium also acts as a secondary messenger for certain hormones, mainly the insulin, parathyroid hormone, calcitonin, vasopressin, etc., from the cells. Then that's what the secondary messenger, calcium and cyclic AMP, or the second messengers of different hormones. Mainly, you can think of glucagon hormone, that is a peptide hormone. Okay, the steroid hormone action is different. You all know it is through the receptor mechanism. So through cyclic AMP. The coagulation is also a major function of the calcium. It is known as uh, factor 6 in the blood coagulation cascade. And then in the myocardium, the calcium prolongs the systole in hypercalcemia. So the cardiac arrest is seen in systole. Then in bone and teeth, the bulk quantity of the calcium is used for the bone and teeth formation. These are the major functions you can write when you have asked about the functions of the calcium. Next slide. Calcium plus colmodulin, calcium binding. Colmodulin, it increases the synthesis of or stimulates the synthesis of kinase enzymes, active kinase. The inactive kinases will become active and the enzyme will be phosphorylated enzyme and it will be leading to the biological effect of that particular enzyme. Next slide. That was the mechanism of action of colmodulin. So, the what are the enzymes that are being activated by this or mediated by colmodulin? Mainly the adenyl cyclase enzyme, calcium-dependent protein kinases, calcium magnesium ATPase, glycerol 5-phosphate dehydrogenase enzyme, glycogen synthase, myosin kinase. All these you can list out. Phospholipase C, phospholipase kinase, phosphorylase kinase enzyme. Then pyruvate carboxylase, pyruvate dehydrogenase. These are the enzymes that are mainly required in the gluconeogenesis, if you remember, where the glucose is being synthesized from the other than carbohydrate sources. Last three. Next slide. So you can remember the enzymes, you can list out 3 or 4 when you are writing in the exam. So now coming to the serum calcium level, what is the normal serum calcium level? You will be asked in your exams. It is usually, it can be taken as 8.5 to 10.5 milligram per deciliter. About 5 milligram per dl of calcium is in ionized form and is metabolically active. Another 1 mg per dl is complexed with the phosphate, bicarbonate, and citrate. And about 4 mg of calcium is bound to proteins in the blood. Next slide. So if the serum calcium level is decreased, what do we call it? It is called as hypocalcemia. And if it is more than 10 mg per dl, then it is called as hypercalcemia. So when serum calcium is low, parathormone is stimulated, resulting in increased calcium release from the bone and decreased renal calcium excretion. That's the action of parathormone. And parathormone also stimulates the increased production of calcitriol, which acts as increase in the absorption of calcium from the intestine. Next slide. This is the illustration. We can make it. Need not draw the diagrams, but write the flow chart like names itself. It will be useful for your exams. Next slide. It is about how the metabolism of calcium and vitamin D3 is interrelated from the bone, kidneys, like that. So calcitonin is secreted in the thyroid parafollicular cells and it decreases the serum calcium level. This is the very important hormone that is secreted by the thyroid parafollicular cells and it inhibits the resorption of bone. And calcitonin and parathormone are directly antagonistic and the parathormone and calcium together will promote the bone growth and remodeling. Calcium level is increased in medullary carcinoma of thyroid and therefore it acts as a tumor marker for the thyroid carcinoma. And the procalcitonin is the precursor of calcitonin and procalcitonin is markedly elevated in acute bacterial infections. So it is usual these days we are estimating procalcitonin level if you are having severe septicemia or like that. Next slide. So the comparational action of 3 major factors affecting the serum calcium, mainly the vitamin D, PTH, that is parathormone and calcitonin. So when the blood calcium will be increased in vitamin D increases the calcium in the blood and parathormone drastically increased. Let me see what is this. Factors affecting the serum calcium levels. This you need not write. Okay. So vitamin D helps in the calcium absorption from the gut, and it decreases the bone resorption, and deficiency manifestation of vitamin D leads to the rickets. You all know rickets in children and osteomalacia in the adults. So the vitamin D will be the drug of choice if you say for the use of rickets. Then parathormone, the calcium, blood calcium will be drastically increased, and it helps mainly the action is demineralization of the bone, and the calcium absorption from the gut is increased by parathormone, and the bone resorption is increased. And if there is a parathormone deficiency, is there tetany will be seen, and uh, in rickets, it is not indicated. Parathormone is not indicated, and this calcitonin is decreases the calcium and it opposes the demineralization of the bone, and there will be bone resorption will be decreased by this one, and it is theoretically beneficial in rickets, but only the drug of choice for vitamin D deficiency rickets is mainly the vitamin D replacement. Next slide. So this is again the relation between the thyroid gland and where there is the absorption of calcium occurs through bone, kidneys, and the intestine thing. Next slide. I didn't go through this slide. Okay. Now coming to the okay. Yeah, effect of phosphorus on calcium. That is, you all we have told that it is reciprocal relationship of calcium with phosphorus. So in hypoalbuminemia, there will be example like nephrosis or malnutrition. The total calcium level is decreased. In such cases, the metabolically active ionized form is normal, and so there will be no deficiency manifestations seen in serum protein malnutrition for the of the calcium. In alkalosis and acidosis, what happens in alkalosis? It favors the binding of more calcium with the proteins, with the consequent lowering of ionized calcium. Here, the total calcium level is normal, but calcium deficiency may be manifested. So the acidosis favors the utilization of calcium. And the renal threshold for calcium is in blood is 10 mg per dl. Next slide. I think so. When to check the calcium level? When there are any neurological symptoms, irritability or seizures, if you see, and there is any, the patient comes with the complaints of renal stones or the colicky pain in the renal colic pain and ectopic calcification of suspected malignancies, polyuria and polydipsia in chronic renal failures and prolonged drug treatments. Next slide. So causes of hypercalcemia, the norm, this you have to very concentrate on that one. What are the causes of hypercalcemia? You have to remember hyperparathyroidism, multiple myeloma, metastatic carcinoma of bone, thyrotoxicosis, Addison's disease, which is the cortisol deficiency. Thyrotoxicosis is increased T4 level, and benign familial hypercalcemia, dehydration, prolonged immobilization, where the patient is bedridden or they are not moving, then there will be definitely there will be hypercalcemia, tuberculosis, leprosy, sarcoidosis, milk alkali syndrome, the drugs that are usually causing hypercalcemia, which who are using the most of the thiazide diuretics. That's excessive vitamin D or A vitamin, excessive calcium given IV, and the lithium. These are the drugs that may cause the hypercalcemia. Symptoms of hypercalcemia: polyuria, polydipsia, confusion, depression, psychosis. Oh God. Renal stones, pancreatitis. Serum alkaline phosphatase may be increased. Management: adequate hydration, IV normal saline. You don't require this one. Sorry, skip the slide. Next slide. Next slide. Yeah. The other condition which is very important, what we see is hypocalcemia. The symptoms will be muscle cramps, paresthesia, neuromuscular twitchings, as I was telling, tetany, that is the Chostek sign. If you tap on the ear, there will be spasm of the muscles will be seen. Then, if you Trojo sign is mainly if you tie the BP apparatus or something to check, and if you increase the pressure, then there will be tetany of the fingers we will be seeing. So then seizures, bradycardia, and the prolonged QT interval is seen in the hypocalcemia. The treatment is oral calcium with vitamin D. Along with vitamin D, if you give, it will be absorbed more. That you remember. And underlying cause should be treated first. Okay, so if it is any deficiency of any hormones or in osteoporosis or anything, you should be seeing what is the cause and then treat them. And tetany needs IV calcium mainly. Usually we will be treating with the IV infusion of the calcium. This is a carpopedal spasm in tetany. This is what I was telling about Trocho sign, and the tie the BP apparatus cuff and increase the blood pressure. You can see that sign. Next slide. Then chronic deficiency of calcium. We will see the white patches on the nails, and also the ridges. We will be seeing most of the ridges will be seen on the nails. So then you can identify whether it is the calcium deficiency, estimate the serum calcium level, and go for the calcium replacement. This is the knock-knee defect of the calcium. Uh, Mostly in the vitamin D deficiency rickets, we will be saying mostly the bow legs. But if it's most calcium deficiency, then we will be seeing the knock knees most defect. Next slide. So what is bone mineralization? It is a process by which the inorganic calcium and phosphates are deposited on the organic matrix and osteoid formation. Then the osteoblasts will be formed, bone mineralized. Then the osteoclasts means which are required for the bone resorption. So the osteoblasts are under the effect of the hormones, parathyroid hormone and the calcitriol. Next. So usually the osteoporosis, it is associated with increased risk of fractures, which is mostly seen in the postmenopausal women, as well as the age, if it more than 60 years of age, the bones will become softened, then it will lead to the osteoporosis. The bone abnormality is decrease in the bone mass, and which attains a peak by the age of 30, not 30, we can say, and starts declining by 35 to 45 years age in both men and women. Let us, yes, we are seeing in young women, men also this, mainly the women, which are, we see the osteoporosis. So at the age of 40 to 45, calcium absorption is reduced and the calcium excretion is increased. So there is an negative balance of the calcium, and this is reflected in the demineralization of the bone. So it is osteoporosis. If it is not identified, it is a silent disease without any symptoms. But in clinical, osteoporosis can be debilitating, and the common sites for osteoporosis fractures include the spine, wrist, and hip. And the bone mineral density is measured by the dual energy X-ray absorptiometer, that is DEXA scan we call it. And if we can identify the osteoporosis early, we can be treated. It can be treated and we can prevent the fractures. Next slide. So you can see the difference between the normal X-ray and an osteoporotic bone. The bones look very translucent. You can see that one with the bone mass decreased in the phalanges. You can see the difference between these two. Next slide. So osteocalcin is a unique protein seen in the bone, found in the bone and dentin, and osteocalcin forms about 1% of the total protein in bones. It is secreted by the osteoblasts and plays a role in mineralization and calcium ion homeostasis. Next slide. Remember, it can be asked as a small short notes. So all these you don't require at your MBBS summer. Just remember the names. Next slide. Is this the last one? Yeah, biomarkers of bone diseases. You can just go through this list of biomarkers. For a metabolic bone disorder, we will be doing all these biomarkers like serum calcium, inorganic phosphorus, magnesium, urinary excretion of calcium and phosphorus, total alkaline phosphatase level, and bone isozyme of alkaline phosphatase. In children, because they are growing, the normal range of alkaline phosphatase is more than 400 is also normal, taken as normal. So remember that raised alkaline phosphatase level is normal in during the childhood. Serum 25 dihydroxy vitamin D will be, if you estimate that, if you find the deficiency, we can replace that with the vitamin D supplements, and the rickets can be treated. PTH measurement, if serum calcium is abnormal, and it is mostly for the adults, and the parathormone deficiency can be ruled out. Osteocalcin, which increases in metabolic bone disease, usually we'll be not doing this. And type 1 collagen telepeptides, markers of bone resorption, these are also very rarely we do as a bone marker. Next slide. Oh, coming to the phosphorus, the total body phosphate. How many more slides are there? Can you tell me, Lasya? I didn't go through that. Total body phosphate is about, yeah. So the phosphorus also helps in the formation of bone and teeth and production of high energy phosphate. This is the very important function of phosphorus. So we have to remember the high energy phosphate synthesis, or it requires the phosphorus, because you all know ATP, CTP, GTP are the high energy phosphates, which are the play a main role in all the metabolic processes of our body. So synthesis of nucleoside coenzymes such as NAD and NADP, these are also very important enzymes that are required for the DNA synthesis, and as well as in the electron transport chain. We all know that for the energy metabolism. Good. Next slide. So the functions of phosphate ions, DNA and RNA synthesis, formation of phosphate esters such as glucose 6-phosphate, formation of phosphoprotein, that is casein, which is the important protein that is also mainly present in the milk again, and activation of enzymes by phosphorylation, which is an important step which will activate the enzymes for the further metabolic process. The phosphate buffer system, this is the one which maintains the blood pH, the ratio of sodium hypophosphate to H2PO4 in blood is 4:1 at pH of 7. So, I mean, you just have to remember the phosphate buffer system in the blood is also plays a major role in the blood home pH balance. Next slide. Blood buffer systems. Phosphate buffer also plays a major role. Requirement and source requirement is about 500 mg per day. Milk is a good source. As I told you, phosphoprotein casein is present in the milk. Cereals, nuts, and meat are moderate sources. And again, calcitriol, which increase the phosphate absorption. And serum level is, I told, 3.4 to 4.5 mg per day. And in children, it is normal range. That's all. In children, it is little high. Next slide. So the causes of hyperphosphatemia, this is very important. Increased absorption of phosphate. So because of excessive vitamin D, if you take more, it will lead to this one. And any phosphate infusions, if it is happening, it will lead to the, again, increased phosphorus levels. And increased cell lysis will also causes increased phosphate level. And chemotherapy, during the chemotherapy for cancer, and during the bone secondaries, this will be phosphate level will be increased. And if there is any decreased excretion of phosphorus due to renal impairment also, we will be seeing hyperphosphatemia. And in hyperparathyroidism, we'll see the increased levels. Hypocalcemia, massive blood transfusions, thyrotoxicosis, and drugs like, again, diuretics that are chlorothiazide. Nifedipine is an antihypertensive, and furosemide is again uh, another drug which causes hyperphosphatemia. Causes of hypophosphatemia: decreased absorption of phosphate, malnutrition, malabsorption, chronic diarrhea, vitamin D deficiency, and when there is an intracellular shift due to insulin therapy, more than respiratory alkalosis, we will be seeing hypophosphatemia, increased urinary excretion, and hyperparathyroidism. Fanconi syndrome, you have to remember, it will be given as a short answer. Hypophosphatemic rickets, this is the one which is also seen in most common apart from the regular rickets. And hereditary hypophosphatemia. And then the drugs, mainly if you take more antacids, diuretics, salicylates, that are painkillers, you will be seeing hypophosphatemia. Next slide. Okay. So in hypoparathyroidism, we'll be seeing increased phosphate with decreased calcium. This is the differential diagnosis you have to remember in renal diseases. These all you don't get in your exams, but okay. Increased phosphate with the normal or increased calcium is seen in milk alkali syndrome and hypervitaminosis D. A decreased phosphate with increased calcium is seen in hyperparathyroidism and sarcoidosis. Decreased phosphate and both decrease in phosphate and calcium is seen in mainly malabsorption, vitamin E deficiency, and renal tubular acidosis. Next slide. Okay. Thank you so much. I have to thank all who have been here for the past 1.5 year, 1.5 hour. Thank you so much for listening to me. I hope it will be useful for you during your exams as well as for your Viva also. So you all take care. Have a very good day, or I mean, very good night, and have a nice dinner. Thank you so much, Lasya, and thanks the NMO whole team who have given me this opportunity. Thank all of you.
We extend our heartfelt gratitude to Dr. Madhavi ma'am for an insightful and enriching session. Thank you, ma'am, for your valuable insight, guidance,
Thank
and
you, ma.
unwavering support.
Thank
We
you
also
so much.
thank all the participants for your enthusiastic presence and active participation. Let's end today's session with Shanti Mantra.
Salvation.
Vedantu Sukhinaha Sarve Santu Niramayaha Sarve Bhadrani Pasyantu Ma Kachit Dukha Bhavet Om Shanti Shanti Shanti. Thank you so much, ma'am.
Thank you, ma. Okay. You can cut the thing.
Okay, ma'am.
Yeah. Thank you, Lasya. Thank you so much.
Thank you, ma'am.